Today, we are going to focus our review on the post-op care of an orthopedic patient. The management of hip fracture in older people in the postoperative setting requires a multidisciplinary approach. The main goals of the postoperative stage are early mobilization and prevention of complications. If you are a nurse working or caring for an orthopedic patient in the hospital, you will be expected to assess the patient's vital signs every 4 hours, document a sepsis screen on the patient within 2 hours, monitor the patient's temperature and heart rate. Tachycardia or bradycardia should be reported immediately. Monitor the patient's blood pressure. Report if they are hypertensive or hypotensive. Check the patient's respiratory rate and oxygen saturation level. And let the patient know to expect a multimodal approach for good pain management. Remember, early and timely pain relief is a care plan to follow to promote your patient's participation in their rehab. Give timely PRN medications for pain, fever, hypertension, or other complaints of discomfort. Let the patient know walking is the best way to help to loosen any phlegm after surgery, promote flow of oxygen to the wound site, and will also help to prevent them from developing pneumonia. One of the quality standards for post-op care is early ambulation and mobilization. For example, shortening the time of bed rest after hip fracture surgery contributes to a reduction of the length of hospital stay and complications such as thrombosis, sepsis, pneumonia, respiratory failure, delirium, and pressure sores. Early mobilization impacts the long-term functional status of patients and improves the likelihood of achieving full ambulation recovery. Please make sure to communicate the patient's ambulation status, including how they ambulate to the bathroom, which adaptive equipments are used, and provide updates to the communication board. When caring for a post-op patient, the nurse or healthcare team member should realize that patient advocacy is a multidisciplinary approach, which is why it is important to keep your communication with the patient up to date. Using the communication board allows a multidisciplinary team to quickly surmise a patient's activity, diet, and pain status. Ask yourself what measures you are taking to prevent DVT in your patient. Does the patient have Nsaids ordered? Any new anticoagulant therapies? What about their pain status? You should establish a pain relief plan with the patient at the start of your care. Let the patient know you will be taking a multimodal approach to pain relief, which will include pain meds and Nsaids. Ask the patient if they would like to use the call light to ask for pain medications. If so, teach them the importance of early pain relief for good pain management and to request pain medications when the pain begins. Example, please use your call light when your pain is a 4 out of 10. Other critical interventions include early ambulation. Maintaining the dressing site is clean, dry, and intact, providing good oral care, using the IS, and documenting strict I's and O's. Always perform a good inspection of the surgical site and the surrounding skin. Observe the type of drainage, if there are any drains or tubes. How about the dressing? Is the dressing clean, dry, and intact? Do you notice any swelling, bleeding, erythema, odor, tenderness, and any reported pain? Do you know the daily WBC count and H&H? How are the patient's results trending? Be sure to document all findings. Surgical site infection is the third most frequent cause of infections. Patient-specific risk factors are older age, poor nutrition, history of diabetes, smoking, obesity, other infections, and previous history of colonization. Prevention measures include perioperative antimicrobial prophylaxis using cefazolin or other antimicrobial agents. Foley catheters are actually meant for longer-term use by patients who have difficulty urinating, obstruction, or have urinary retention. Always document the justification for a Foley catheter that is in place. Mention the clinical indication in your documentation. In the post-op patient, they should be removed as soon as possible to prevent infection or prolong hospital stay. The nurse should closely monitor the patient's urine output and prepare to bladder scan if the patient does not void within the next 4 hours. Straight catheters are simply straight tubes without the balloon feature of a Foley catheter and are meant for quick drainage of the bladder. They are not for long-term use. Bladder volumes between 300 and 500 ml are commonly used as thresholds for bladder catheterization. Follow your MD orders for this patient. Post-operative patients can have complex reasons for low urine output or oliguria. Notify the provider for urine output less than 30 ml per hour. Document all findings. Thank you for watching this quick learning video. Please like and subscribe to help our AI channel grow.